Well, thank you very much, Phil, for those welcoming words. And can I just say how delighted I am to be here today to address this distinguished audience. It's been a rough old time over the last 18 months, and I do feel that we are right now poised at the commencement of a set of changes within the NHS that can be truly transformational, and that everybody in this room is part of that transformation. The first thing I have to do this morning is to thank everybody. Let me explain why. 18 months ago, on the commissioning side of the NHS, there was an employment of around 50,000 people. In the period since then, that number has come down to 33,000, so there has been a loss of 17,000 posts on the commissioning side of the NHS. That's partly through natural attrition and partly through redundancy. It has reduced the overhead cost of commissioning. It's also lost us a lot of valuable corporate memory. In the case of NHS England, on the 30th of March this year, we employed something like 100 full-time equivalent staff. On the 1st of April, we employed 6,300 permanent full-time staff. Of the remaining numbers of that 33,000, some 9,000 have transferred into the CSUs, and others have gone into CCGs and to other employment within the system. Now, you may know better than I, but I cannot think of another reorganization of that magnitude that has gone so quietly. As I've explained to the Health Secretary, and frankly anybody else who will listen, there is that wonderful Conan Doyle story about the dog that didn't bark in the night. And actually this reform was the dog that hasn't barked or yelped or squealed or howled to the moon in the night. And why has it happened? I would say it's happened through a combination of careful, meticulous planning, but it's also happened as a consequence of immense commitment and hard work by everybody who's been involved. And that's why I start this morning by saying thank you to all of you who have been through a complex process, one which must have been very demanding in terms of workload, but one that also carries a high emotional cost. People have not been clear for some months what would be their future, where they would be employed, what would be their job. But more than that, what would be the culture within which we're now working? And for us at NHS England, that is probably the most fundamental and critical question. It's not just a matter of moving into new buildings and having new logos and new management structures. It's something that we believe comes fundamentally from the Francis Report. But the Francis Report, it was an opportunity for a lawyer to cast a spotlight on some of the dark recesses of appallingly bad practice in the NHS. But beyond that, we know that's not a universal issue, but we do know that there is fundamental public concern about the quality of care and the attitude sometimes encountered within the providers and the commissioners within the NHS towards patients. We can only overcome that by having patients absolutely at the heart of the system. So when anybody asks us at NHS England, what are you for? The answer is patients. Now, I want to just spell that out a little more clearly, because I don't think it's fully understood what it is that the Prime Minister and the coalition government have expended their political capital on. Yes, the most fundamental reform. Yes, the reform which David Nicholson described as being so big you could see it from open space. That's David's classic understatement, a habit to which he's prone. But much more than that has been a change towards a model which, to use the language of Lansley's white paper, was about liberating the NHS. Well, liberating it from what? Liberating it from day-to-day political operational control. The idea of setting up NHS England was to, for the first time, create a body which had on it a majority of non-executive directors, and to establish that in primary legislation. The point about primary legislation, of course, is to create some insulation for the new body, because it must take primary legislation to reverse that. And given the febrility of NHS reform, given the frequency of changes of political leadership of NHS over the past 2 decades, and when there has been a new health secretary on average every 2 years. So it's important, if we're to have the stability that we need to look ahead for 5 years and to 10 years and to transcend political time cycles, it is important to have a body that is stable, which has non-executive directors in the majority and has a strong executive team. Within that, what we've been trying to create is something very, very unusual in the new model, which is what we would call a unitary board. I can't stand being on boards of directors where the non-execs come in, not having read the papers properly, and challenge the executive team and then walk away as if the rest is not their responsibility. That is not acceptable behavior. So what we have done is decide we'll have a unitary board in which everybody's a non-exec except the executive who's presenting the paper. They are challengeable by everybody else on the board, but by having a unitary board, so we can bring into play the huge talents that come from the non-executive members, 6 other members in addition to myself and the chair, to the benefit of the NHS. And we have non-execs coming from the voluntary sector. Victor Adebowale and Kieran Devane, for example. Kieran is the CEO of Macmillan Cancer Support. We have Margaret Casely-Hayford, who is the company secretary for John Lewis. If there is one company that satisfies the requirements of customer satisfaction in this country, it is John Lewis. We want to try and extract what we can from the non-executive team and bring it to the aid of NHS England. But the other great asset that we've got is the budget. So as part of this new settlement, the NHS commissioning budget of £96 billion is transferred from the Department of Health to NHS England. This, by the way, is not for us to spend as we would wish, but for us to spend to invest against health outcomes for the nation. This is a transformation, by the way. Those health outcomes are specified in a mandate that is given to NHS England, which has 5 domains, against which there are metrics to measure our performance. Domain number 1, which is reducing premature mortality, a fundamental requirement for advancing the health of this nation. And if we look at our performance against the EU 15, the 15 members of the EU prior to recent enlargement, we can see from a paper in the Lancet earlier this year that not only were we in 1990 below the median, but that our performance has worsened since then as a nation. And much of that is premature mortality due to tobacco, obesity, alcohol, drug abuse, but also, if we want to put that more widely in the context in which commissioning really has to be active, in the whole area of health inequalities, inequalities of social advantage and inequalities in terms of access to health care, but also those health inequalities of deprivation which lead to people leading unhealthy lifestyles. The other domains include, obviously, improving the quality of life for people suffering from long-term conditions. We all know from the demography that an increasing proportion of the population is in that category. And dealing effectively to promote rapid recovery from those suffering from injury or acute ill health. The other 2 domains are around patient safety and patient satisfaction. So instead of ministers, as has historically been the case, following the Nye-Bevan injunction. The Nye-Bevan injunction was that bedpan that was dropped in the corridors of Tredegar Hospital would reverberate down the corridors of Whitehall, which is always the wrong model, by the way, for political leadership of a National Health Service, is now consigned to the bedpan. And what must follow is a model in which ministers are accountable to Parliament for the overall performance of the NHS, and we are accountable to ministers against those criteria and against the metrics. What that means for all of us in this room, I would say, is that we have a new duty, which is not to be worried about political short-term aims, although of course we are worried about ensuring that the salience of particular issues such as A&E and 111 are quickly sorted out, but that we've got to ensure that over the next 3 to 5 years and the next 5 to 10 years, that every pound that we invest delivers maximum value to patients. Every pound for every patient equals maximum value. And that, I think, for commissioning support and for CCGs has to be the central principle. Of the 95 billion, we have assumed the following allocations, and I'm going to give them to you in very crude forms. First of all, the great bulk of that budget is transferred to clinical commissioning groups. We have 211 CCGs. We put them through a rigorous process of authorization, but it was not a top-down process. The first evidence, if you like, of our new culture was to work with CCGs through a development process to come through the authorization gateways, and I was really delighted that the outcome of that was that the great majority of CCGs were authorized without conditions and are now strong and vibrant organizations. Those who are still to come through the final processes have our full support. We work with CCGs in a role which is facilitative, not directive, not top-down, not in a dirigiste way. And please, if your experience is to the contrary, don't hesitate to let me know. We are going through a difficult transitional period in which behaviors and cultures will change, but I personally regard the CCGs as the engine room of the new NHS. I have seen astonishing, outstanding, imaginative, innovating and exciting things going on in CCGs. Stuff that I had secretly hoped for and prayed for, and it's starting to come through. It's all about leadership and it's all about inspiration. But the CCGs will also only work really well with strong commissioning support. And by that we mean support which is not only efficient, sharp and clear on transactional work, but also on transformation of services. I'll come back to that. The second big area of allocation of our budget is now around specialised commissioning. So that has gone up in national terms from 8 billion to 12 billion, and that will mean that we're able to draw together what previously was a variety of regional practice and success into a single national specialised commissioning model. Alongside that is our responsibility for primary care, including general practice, and our need to think with you, with CCGs, and with our other stakeholders about what is the future for primary care and the relationship between primary and secondary care as we look forward over the next 5 to 10 years. It's not easy to break from a cycle of annual review of the GP contract into thinking, well, 5 years ahead, what should primary care be looking like? And I am looking to CSUs and CSSs more generally, and also to CCGs to help us through the thinking that will take us to where we need to be. Because beyond all of this is the financial framework. I think we're all conscious that since 1948, the level of investment that the nation has put into the NHS has been at 4% real per annum, compounded over that time. So even if you look today, in today's value at the level of investment in the NHS in 1948, it was under 20 billion in today's value, and it's over 100 billion if you take the present day figures. So we have extraordinarily invested in one of the finest healthcare systems in the world. But that stopped. The Institute for Fiscal Studies for the Nuffield Trust report last year is the most chilling document that you could read. The anticipation is that we will be lucky to see zero real for the next 5 years, if not the next decade. But that, of course, doesn't subside demand. Demand is continuing to grow at 4 to 5% per annum. So we have this extraordinary challenge, which everybody in this room has to own, this extraordinary challenge of how we continue to create a world-class healthcare model without the resources that have been pumped into it historically. The coalition government has committed to a ring-fenced budget for the NHS, but even that is under the most suspicious scrutiny across the rest of Whitehall through the current spending review. It's, I think, apparent to everybody that the only way in which we can deliver real value for patients is through the most significant transformation of the delivery of services, in a process in which nothing is taken for granted as we go through the next few years. Now, in the new devolved model of the NHS, This is not for NHS England to specify what will be there in 10 years' time. It's not for us to say, this is where we're going and this will be the outcome. It is for us to work with you to steer a process through that can help us think with stability in the background about the next 5 to 10 years. And to try to draw into these discussions the commentariat and other stakeholders in the political framework to try to ensure that we're totally focused on value to patients over that time. That is, I think, our most difficult challenge. We will later this year be launching a strategy paper which will not be a strategy but which will be a pathway to developing a strategy. A paper which will involve the discussions that are appropriate in the new model of the NHS, which is not top-down but which is bottom-up and which is working with everybody in this room and way beyond. You who work in CCGs have many of the answers in your hands already. Fundamentally, between us, we've got the duty of making commissioning work. We had a presentation to the board of NHS England earlier this year from Paul Corrigan, one of the really respected commentators on health policy, who put the proposition to us that commissioning never has worked in the past. And our challenge was to find out why that was the case and how we make it work now. How we move from commissioning being a neutral conduit in which money is transferred from one party to another to being a challenge process in which value is sought for every investment in commissioning. So I hope that gives you some understanding of the way in which we at NHS England are approaching our responsibilities, working in a facilitative fashion with CCGs, and then working in a developmental way with commissioning support. The place where we have got to with commissioning support is that just last year there were 90 potential CSUs. By working closely with that number and by facilitating mergers and joinders, we've brought that number down to 19. We wanted to be sure that we had 19 financially viable and effective CSUs. I believe that we have now got to that position. We are in transition. For the first 2 or 3 years, the CSUs will be hosted by us, but with the Business Services Agency of the NHS providing the employer relationship. We will be looking very closely as relations develop and trying to achieve 2 things. One is trying to ensure that the commissioning support services, whether they're through CSUs or elsewhere, are the best they possibly can be. I'm not interested in mediocrity or second rate. I'm not interested in history or tradition. I am interested in the best they could possibly be. And actually the buying of services by CCGs has also to insist that those services are the best they can possibly be. And there will be competition between CSUs and other models of commissioning support to ensure they are the best they possibly can be. We will be wanting to monitor that very closely and to work on it. Secondly, we will want to ensure that the transactional service that is given to the CCGs is absolutely outstanding. But we want also to ensure that there is an interaction between commissioning support and CCGs that allows CCGs to be the best clients they could possibly be. Now, that sounds almost ironic, you know, who's the master and who's the servant? But the reality is that this is a status of interdependency. I can understand that CCGs will generally be very positive about their ability to be strong clients on the transactional side, but we have to push that into the transformational side. How can we develop CSUs and CSSs to be the finest thinkers about transformation of services and to be able to mediate that intelligence to CCGs, to allow CCGs to learn from best experience elsewhere and to apply it as appropriate in their areas? We've not been very good historically at transmitting experience within the NHS. And one of our fundamental ambitions is to be a model of open transmission and open communication, to use NHS IQ and other agencies, the Leadership Academy, to try to ensure that you who are the actors who will bring about these transformations are well and strongly supported. So I'm very pleased today to announce that we will be today launching first our new strategy, entitled Towards Excellence. I'm sorry, you do run out of inspiring titles after a while, but Towards Excellence, which is our new strategy around the development of commissioning support. And I'd be identifying 3 key strands, so forgive me if I just spend a little time on each of them. First, enabling CCGs to exercise informed choice of how they source their commissioning support and from whom. And as a first step, we've launched a new app, which is on our stall. It's on the CSSS stall today. It's being demonstrated. So please have a look at that. And please look at it critically and tell us whether it works. And if it doesn't, what it needs to be further developed. We do everything that we can do in terms of co-creation. Secondly, the second strand of the strategy is developing a strong cohort of excellent CSS providers. We're going to also work very hard at bringing in voluntary organizations, and I'm delighted today that we are also publishing an agreement we have signed with Archivo. I have to say, one of our jobs is to break down barriers, and to break down barriers between commissioning support, CCGs, and the voluntary organizations that provide so much support and input to healthcare and its organization in this country is fundamental. I'm delighted that we are able today to launch that agreement, and I look forward to the promise that it will bring for the future. The third thing that we are concentrating on in the strategy is trying to focus on procurement mechanisms. I think everybody is daunted by OJU. The prospect that you can't do anything under OJU without expending millions of pounds in 24 months, by which time the problem that you're trying to solve has either gone away or has become exacerbated. We will work very, very closely to try and ensure that we have a simplified process that is fully legally compliant, but nonetheless enables fair, open competition on an efficient basis. So we're starting today a full consultation with CCGs, with providers and other key stakeholders on what those frameworks would be. You may be aware that we've also published a 2-pager with Monitor about competition within the NHS more generally, and that the starting principle is this is about patients. What is the model that best satisfies the needs of patients? Provider support is of course important, and providing stability on the provider side is important, but this is about patients. Phil, thank you very much.
Thank you so much. Come and join me if you would, Malcolm. It'd be good if we had a few moments for questions. Just to get the ball rolling, can you get ready to put your hand up so we can get a mic to you? But in the meantime, could you give us a 2 or 3 sentence word picture of what you would see as a successful and excellent CSU 3 years from now?
I don't want to try and boil everything down into such a brief compass, but if I were to do it, I would say it was a CSU that was so successful that CCGs were queuing up at the door to buy its services. Okay. I really think that is the test.
So it's about being very, very much customer focused then?
Totally customer focused, but remember that the ultimate beneficiary is the patient. But I think we are in a competitive environment for commissioning support, and it has to be about what CCGs identify as best practice, best support, as appropriate for their patients.
That's very helpful, thank you. So question here.
My name's Liz Brutus from Croydon Council Public Health. Just wanting to know what you see as the interaction, the interface between the CSUs, the CCG, and public health and the local authority. Mm-hmm.
I think, from what I was saying earlier about premature mortality, we know that this is a long-burn public health issue. And I think one of the advantages that we've got of the new model is that the operations between CCGs and local government are much more open than previously they were. When we authorised the CCGs, we were quite insistent that there was a local government representative on the panel that we met and we interviewed and we spoke with them. We have the health and well-being boards, which I see as a vital relationship between local government and the CCGs. We also have a new body called Public Health England. Now, we are taking on some limited public health responsibilities, for example, inoculation vaccination comes to us, and that's a contract arrangement. But by and large, public health is going to be driven by Public Health England. One of my major responsibilities, I have to confess, is trying to ensure that they and we are joined together at the hip, and that we're also joining closely with the local government association. We've had several meetings with the LGA, and we're going to be working closely with all of them. One of the problems, I think, of the organisation in the past is that it's been a set of silos which have been driven by a divide and rule mentality. One of the opportunities we've got with the new model is actually overcoming that and having much more joinder. So public health is critical. We won't win without big advances in public health.
Thank you.
John Wilderspin, I'm the Managing Director of Central Southern CSU. So first of all, welcome a sense of ambition around commissioning support, but also the focus around how do we add value to patients and the public in supporting CCGs. Building on the previous question, can you say a bit more about how you see commissioning support providers working with other supportive organisations? You mentioned NHS improving quality. We're already working with Public Health England. Are there other bodies that you think we should be working with to provide really excellent support to commissioners?
I wouldn't want to be determinative on that because I think you will find your own way very quickly of the bodies that will work closely with you and give you support. I think also it will be determined by what the CCG's expectations are, and they also will be working extensively in their local areas with networks of people. And the so often overlooked area, often within a political framework, is the voluntary organisations. There's an enormous wealth within voluntary organisations, both national and local, and I would have thought that they were a very important part of the network that you'll be operating within. Can I just stress, so much of the new model is networking. Networks often sounds a bit wet. It sounds like a cocktail party. Well, it's not. I mean, networking is a very, very powerful mechanism for understanding what other people's objectives are, what they want, and how you can achieve them through close cooperative working.
Fine. Then we have one very quick question. I've asked you to keep it very brief. Just down here, please. Have we got the mic here? At the front, in the middle, please.
It's so dark, it's difficult, I think.
Very, very quick question. Keep it brief if you would.
Hello, Michael. My name is Krishna. I'm a senior lecturer in University of Bedfordshire. I just want to ask one simple question. What would be academic public health, or public health who deals mostly on academic training and teaching on your new strategy?
Well, I don't, sorry, academic public health. I'm an academic, you see, so I'm all in favour of that. But it's very interesting that the chairman of Public Health England is a very distinguished academic, David Hayman, who comes from the London School of Hygiene and Tropical Medicine. Public health needs, I think, the strongest input from academia, which is to a large extent around epidemiology. It's understanding populations, it's understanding demographic change, it's understanding what are the causes, particularly of multiple long-term conditions. But practical public health is what needs to be going on, and that is not solely a function, of course, of local government, where public health has a particular historic focus. But I would say critically of primary care. I think our GPs are major actors in public health.
Absolutely.
But this is a real difficult issue, isn't it? I mean, if you go back to those things that I was mentioning before that the Lancet paper has identified as major failings within Britain, they're lifestyle choices determined by, or within a framework of health inequalities. So it's not perhaps surprising that Nye Bevan was both Minister for Health and Minister for Housing. And he saw housing as a major determinant of health. So I think it's academic and it's practice.
And of course that brings us back to the health and wellbeing boards,
Yes.
inevitably. Professor Grant, thank you so much for coming and presenting to us. We really appreciate your time. Thank you all for being here. One final thing, please take all your papers and rubbish with you so that this room is ready for the next session. But let's say thank you to Professor Grant in the normal way, shall we?
Thank you for the opportunity. I much appreciate it.
Really appreciate it.